Greetings from the city of oranges. At the onset, I would like to thank the office bearers of the Indian Orthodontic Society, Honorable President and Secretary Ma'am, and the Scientific Committee of the OrthoBite 2020 for giving me this platform to present before you with the topic Contemporary Management of Vertical Discrepancies. Ideally, this topic should be covered under the following heads: the types of vertical discrepancies, the development of the vertical problem, the definition, classification, and etiology of open bite and lip bite, the clinical diagnosis, cephalometric diagnosis, treatment planning considerations. But because of time constraints, I will directly switch on to the treatment modalities for open bite and lip bite in children and adults with the retention protocol. Vertical discrepancies are the challenging malocclusions. Right since the orthodontics became a specialty, this vertical discrepancies has been studied and debated, and there is very little literature on the management of vertical problems. Vertical problems has been less discussed in the past and even in the present as compared to the sagittal and the transverse discrepancy. Vertical discrepancies pose a challenge because it is often associated with a sagittal and a transverse discrepancy also. Broadly classifying the vertical discrepancies, it could be an increased vertical height or a decrease in the vertical problem. When it is an increase in the vertical discrepancy, it leads to a long face, increased lower anterior face height, steep mandibular plane angle, and obtuse gonial angle associated with an open bite. When it is a decrease in the vertical discrepancy, then in that case, you get a hypodivergent mandible, a short lower anterior face height, a long ramus, and a deep bite. Also, you get a vertical maxillary excess where the maxilla is at fault, but the maxilla descends downward, leading to a gummy smile, which could be associated with an open bite or a deep bite. So why a vertical discrepancy? If we go back to our basics, the normal growth. The normal growth takes place with a balance of the condyle and the fossa growth, which balances the vertical growth taking place at the maxillary suture, the maxillary alveolus, the mandibular alveolus, and the eruption of the posterior teeth. Whenever this balance gets disturbed and the vertical growth exceeds the condyle fossa growth, in that case, a clockwise rotation of the mandible takes place, leading to hyperdivergent faces or the long faces. When the condyle fossa growth increases or exceeds this vertical growth, then there is an anti-clockwise rotation leading to a short lower face. So added to this is an environment. The environment could be the swallowing pattern, the breathing pattern, the tongue posture, which adds to this growth, and there is an interplay between growth and environment in the etiology of vertical discrepancies. Cephalometric consideration, we have to go through all these parameters to come to a diagnosis whether it is a skeletal open bite or a skeletal deep bite. Soft tissue also needs to be considered. The incisal show at rest, the smile line, the lip line, the facial height, and very important in the treatment consideration is the age. The in-growing children, the treatment modalities will differ than in the non-growing adults. So let's come to the management of open bite, which could be a skeletal or a dental. It could be an anterior open bite. It could be a posterior open bite. It could be because of the supra-eruption of the posteriors or infra-eruption of the anteriors. And let's see the management in growing patient. Now, if in a growing patient, the habit is the cause or the etiology of the open bite, which leads to a dentoalveolar open bite, then habit-breaking appliances work best. But if the open bite is a skeletal open bite, then our treatment objectives in a growing child are to promote the vertical condylar growth, hold the vertical overdevelopment of the maxilla. If possible, an active posterior intrusion should be carried out and improve the muscle strength, which will maintain the corrections post-treatment. So posterior bite blocks work best in cases of growing child with a skeletal open bite because it promotes the condylar growth, it increases the muscle strength, it prevents the eruption of the posterior teeth, and in turn that leads to the stability of the results. Now the posterior bite blocks can be a passive bite blocks, but For active intrusion, you can put an active component, as in this case, we have put a springs in the byte block. It is a spring-loaded byte block, and this case report has been published in AJDO 2011. A 9-year-old child was there in whom the skeletal open byte was there associated with a thumb-sucking habit. And we gave a spring-loaded byte block, and in 8 months, the corrections were achieved, after which we gave a passive posterior byte blocks. Now, when you give an active posterior byte blocks in a growing child, the muscle strength increases, which further prevents the supraeruption of the posterior teeth. So, another active component which can be added in the byte blocks are the magnets. And we conducted a study where we saw the treatment results with the spring-loaded byte block as against the magnetic byte blocks. And we found that magnetic byte blocks brings about a true intrusion of the molars as compared to the spring-loaded byte blocks, where there is an intrusion of the molars with an extrusion of the incisors. Magnets have a continuous force which brings about a true intrusion, as well as it creates an electromagnetic field which further improves the result. So this was a case where we have given a magnetic byte block, and in 8 to 9 months in a growing child you get the corrections. Now further, my student, the same who did the spring-loaded byte block dissertation, he later modified the spring-loaded byte block by adding a Z-spring-like configuration in the posterior byte block, which holds the posterior byte blocks. And another third modification was a pallet-free spring-loaded byte block. Even the functional appliances can be given in a growing vertical discrepancy. Though functional appliances are indicated for horizontal growth, as you get more of a horizontal correction or more of a horizontal increments. But functional appliances like a V activator, an open byte bionator, or a twin block, where the vertical height of the construction byte should be more as compared to the sagittal. No trimming should be done in that case. And for sagittal increments, you can add an activation, a slow activation, incremental activation can be done. You can add a tongue spikes or an expansion screw along with the appliance. Now, this holds the vertical. It prevents the eruption of the posterior. It increases the muscle strength, which are the objectives in a growing child of skeletal open bite. So this was a case in which we gave twin block with the increased vertical height, and we got the corrections, but the corrections take longer time, and we get more of a dentoalveolar correction in cases of vertical growth. So it took almost 12 months where we got this result. Even orthopedic appliances works well. The headgear, the high pull headgear, the vertical pull headgear properly has to be planned, the force direction to be planned according to the palatal plane inclination, where you get the intrusion of the molars as well as distalization. So this was a case with us, a 13-year-old female, and she had two occlusal planes. As can be seen over here, she had a hyperdivergent mandible. Now, in this case, we wanted to close the open bite not by extrusion of the incisors, but by intrusion of the posteriors, and we gave a high pull headgear in this particular case. After the occlusal plane leveled anterior and posterior, then extraction was done and retraction was done. With further retraction, the bite deepened and we get a normal overbite. But when it is an adult skeletal open bite, either the options are camouflage or surgery. And in camouflage, you can do an extrusion of the anteriors, intrusion of the posteriors, or a combination. And the best in cases where the face is anesthetic, where it is a skeletal open bite, orthognathic surgeries work best. So extractions are indicated favorable in cases of skeletal open bite, as with retraction, the bite deepens. When intrusion of the posteriors is to be carried out, when we can't afford extrusion of the incisors, depending on the incisal show at rest, then in that case, intrusion of the posteriors can be carried out by making use of the buccal tabs. But when you put the buccal tabs mesial to the first molar, it can cause a buccal flaring of the molars. So in such a case, a palatal tad also should be given, and the buccal and the palatal tad will prevent the eruption as well as the flaring of the molars in that case. When the TADs are given, the buccal and the palatal along with the posterior bite planes, the posterior bite planes will bring about further intrusion of the posterior segment, as well as because of the increased vertical by placing a posterior bite block, it increases, there's a stretch of the muscle and it increases the muscle strength. Even mini plates can be placed to give an intrusive force to the whole of the posterior segment. And now the bone screws have come, which are less invasive. So this is a study of ours published in the JRS 2012, a case report where implant supported bite block was given in an open bite case in an adult patient. So the patient, almost 21 years old, a female patient was there, a skeletal open bite. You can see the steep mandibular plane in this particular case. There is an occlusion, no occlusion, right from the mesial of the molar to that of the other side. In this case, we placed a zygomatic implant and a posterior bite block was fabricated, which maintained the transverse width, prevented flaring of the buccal flaring of the posterior segment. At the same time, on the buccal side, a wire framework is seen to which an intrusive force was attached. So even in the molar, we place a TAD to hold the mandibular molar, preventing its supra-eruption. So here an intrusive force is there of almost 300 to 350 grams given by means of a coil spring to the posterior segment. Intrusion was carried out and we got a very good results in a short time. Now, when patients are ready and there is a skeletal open bite or this long face is because of the vertical descent of the maxilla downward, which we call as a vertical maxillary excess, then the best surgery is superior impaction of the maxilla. And in the hierarchy of stability of the orthognathic surgery, the superior impaction of the maxilla stands first. So they are more stable surgeries where post-surgery the relapses are less. So in this particular case, the patient was ready. We did a Lefort-1 impaction with a genioplasty and we got a very good results. Because of time constraints, I just can't show the complete records of all the patients in this presentation. But now, when the patient is not ready for surgery, the question comes what to do. Now, this was a case, a very interesting case. She was almost 21 years old, and she had the Cox analysis showed all features of skeletal open bite. In this case, the patient was not ready for surgery, and therefore we did extractions for intrusion of the anteriors as well as retraction. Even the molar was held, preventing its eruption so that this gumminess doesn't worsen. And we got the corrections. There was a significant correction, but now the patient complained of the gummy smile. So what to do? So this was the prediction here. We had told her that a Lefort-1 superior impaction was needed of 5 mm with a 6 mm of reduction genioplasty. But when patients are not ready for surgery, then what? So this is a very important article, a very interesting study carried out by Johnny Liu. We just had his webinar on our iOS platform. And in this study is published in Seminars in Orthodontics. Nikhilesh Vaid is also there, our president of the World Federation of Orthodontics. And in this study, the authors have said that we know about the maxillary miniscrew for impaction or intrusion of the maxilla, but they studied the contribution of the mandibular miniscrews. And another concept which has been put up is extra-alveolar implants, which will not interfere in the tooth movement and from which forces can be given for intrusion of the maxilla and intrusion of the mandibular dentition. And a very beautiful term they have given is orthognathic-like orthodontics, means orthodontics simulating orthognathic surgery. So this is a case report given by Johnny Liu in the book Application of TADs in Adult Gummy Smile. And this was a patient almost 35 years old and she had all features indicated for surgery, the superior impaction of the maxilla, but the patient was not ready. So in this particular case, they placed TADs subapically in the anterior between the maxillary, central and the lateral bilaterally. Then they placed a TAD in the mandibular arch between the mandibular central incisors subapically, 1.4 into 7 mm. They placed a TAD in the posterior region for intrusion of the posteriors at the zygomatic crest, 2 by 10 millimeters, extra-alveolar at the zygomatic crest, and in the mandible, they placed again a 2 by 10 millimeters microimplant in the buccal shelf. So with this, they brought about intrusion of the maxillary dentation or the maxillary occlusal plane upward, the mandibular occlusal plane downward. As a result, the mandible could auto-rotate, the mandible auto-rotated, and the open bite corrected, the gumminess corrected, as can be seen over here. So they got almost 6 mm of intrusion of the maxillary incisors, 5 mm of intrusion of the maxillary posteriors, 2 mm of intrusion of the mandibular incisors, and 2.5 mm of intrusion of the mandibular molars. With this, the mandible plane closed down by 4 degrees, and then the chin point came forward by 6 millimeters. So the recessive chin which was there, that also gained some amount of prominence, though the results we can't say as an ideal. The author claimed it in his case report, but at least an acceptable good results where there was no gumminess now, and the overbite and overjet was quite normal. What about the retention in cases of open bite? So this is a systematic review and meta-analysis published in Progress in Orthodontics, where they have studied the stability of anterior open bite treatment with molar intrusion using skeletal anchorage. And the authors concluded that molar intrusion using TADs can be considered relatively similar to that reported to surgical approaches. Means by surgery, what corrections you get, and by TADs, what corrections you get. The corrections, almost a relapse is there in both the situations, around 10 to 30%. So that is what the authors concluded. In growing children, the posterior bite planes should be continued after corrections till growth completion. And this was a study, the same group of patients in which we gave a magnetic and a spring-loaded bite blocks. We gave a retention for 1 year with a posterior bite blocks. After that, no appliance was given to the patient. And 5 years after, we again studied these samples and we found a success rate of 85.8%. Why are the results stable? It is because of the increase in the muscle strength, which is brought about by these posterior bite blocks. So we recommend that passive posterior bite blocks should be given to prevent supraeruption of the posteriors. Coming to the management of deep bite, decrease in the vertical discrepancy, which could be because of skeletal nature or a dental. It could be because of supraeruption of the anteriors or infraeruption of the posteriors. As we all know, growing patients with deep bite often is associated with a skeletal class 2, and the functional appliances work best in those cases because you get more of a horizontal increment. There's an opening of the bite, there's an opening of the mandibular plane because of the trimming of the appliance, and this is a case with a twin block where we got the beautiful results and the deep bite was corrected. Even orthopedic appliance, the cervical pull headgear brings about distalization of the molar and extrusion of the molar, which further makes the mandible open up and you get the results. Now, in adults, you have the choice, again, of camouflage or a surgery. And in camouflage, you can bring about proclination of the incisors, intrusion of the anteriors where not required. Then in that case, extrusion of the posteriors or a combination and orthognathic surgery. So when you give a fixed appliance in cases of deep bite, we consider where we want intrusion of the anterior, the brackets are placed slightly incisally or occlusally. The second molars are banded right from the start, and we give a curve of spee wire in the upper arch and the reverse curve of spee for the lower arch for intrusion of the anteriors and for extrusion of the posteriors. But with this, the anteriors procline. So this is what happens with the curve of spee wires. So where you do not want proclination of the anteriors, especially the lower anteriors, This is a beautiful modification given in Dental Press Journal of Orthodontics 2018. Renato has given an early vertical correction of the deep curve of P by giving a cantilever spring. And this cantilever spring he has given during the alignment phase. Now, when you want to open the bite, you have to switch on to the rectangular wires, which take time because first phase is alignment and leveling, second is the transverse correction, and then comes the vertical correction. So in order to reduce the time, treatment time, the author says right from the alignment stage, when a flexible wire is there, a cantilever spring can be given in the auxiliary molar tube in a 1725 TMA, where it is engaged between the lateral incisor and the canine. This will bring about intrusion with no proclination of the anteriors. So this we had tried in one of our patients, we have given it, and we did get a correction. Curve was P also leveled by intrusion of the anteriors with no proclination, and the alignment and leveling also took place simultaneously in 4 to 5 months. Now, often the deep bite is because of the tipping of the molar when the first molar is not there. So in such case, the second molar tips and we need to do an uprighting, which can be done with a T-loop, cantilever spring, or implant supported, as this modification is given in Progress in Orthodontics 2018 by placing an implant in the retromolar region and giving a distal force to that mesially tipped molar. Now, we often get a class 2 due to like situation like in this patient where there is 100% deep bite. And here we need an intrusion. And since the incisors are retroclined, we need a proclination also. So in such a case, the protraction utility arch works best. You can procline the incisors, you can intrude the incisors, and then when you procline the incisors, the jet increases. Since it was a class 2, with the fixed functional appliances, the force is resistant, the mandible could be jumped forward and we can get the results where the bite is brought to normal, 100% deep bite gets corrected, and the molar relationship is brought to a class 1 where the results will now remain stable. But where you do not want proclination of the anteriors to take place and only intrusion is needed, then in this case, we can give a rickets intrusion arch, as is given in this case. There was a crowding, FOFO was extracted, we unraveled the crowding, and in a 1725 TMA wire, a rickets intrusion arch is made, which intrudes the anteriors, the incisors, without proclination, and we get the results. Now we know about implant-assisted intrusion. So when an implant, a microimplant is to be placed for intrusion of the anteriors, incisors, where to place it? Between the central incisors or between the lateral and the canine, which we say as the CR of the 6 anteriors. So this is a study beautifully carried out by Bharatiya Vidyapit College, Pune. Our student is there, Dr. Veera. So they have compared the effects of these two different positions, and they found that there is an intrusion in both the positions when you place a microimplant between the central incisors or when you place it bilaterally between the lateral incisor and the canine. But there is a more of a proclination of the incisors when you place it in midline between the two central incisors as compared to when you place it bilaterally between the lateral incisor and the canine. Now you get cases where it is a long phase but no open bite. There is a deep bite, as in this type of case, and the bite is also not coming. So in such type of cases, you want intrusion of the anteriors. You just can't afford extrusion of the posteriors, as it will further worsen the aesthetics and rotate the mandible clockwise. Now, when you want the intrusion of the incisors, this is a beautiful modification given in AGODO 2013, where they have used mini screws for indirect anchorage to intrude the lower anteriors. So they have given an utility arch in a algilla which is made in this particular case, and to this utility arch, the intrusive component or the force is attached from the lower anteriors. So we also in this particular case extracted the lower incisor as we wanted a jet, we wanted a correction of the proclination. At the same time, we wanted intrusion of the lower incisors. So we gave the indirect anchorage from the mini screw, to which the vertical elastics were attached. Each end was attached for the intrusion of the lower anteriors. The lower anteriors intruded, it retracted, we got it overjet, and we then did a mandibular advancement in this particular case, and we got the results. Now, in adults with a skeletal deep bite, surgery is the best option, as mandibular advancement surgeries stand second to superior impaction of the maxilla in the hierarchy of stability. So this is the case with the class 2 due to features, we aligned it, and then in this particular case, BSSO was done for mandibular advancement. At the same time, some amount of clockwise rotation we wanted. So that was also brought about during the placement of the plates, and we got the results, and the patient has a very good aesthetics. What about retention in cases of deep bite? We give an anterior bite plane, which is a normal conventional method. Now, this is a study where a long-term follower, 5 years after the corrections, they have studied the stability and relapse after orthodontic treatment in deep bite cases, published in EGO 2014. And they concluded that relapse is seen when a curve of P was not completely leveled at post-treatment, at the end of the treatment, or patients who had a partially corrected but persistent deep bite, as only the upper arch is treated and no treatment is carried out in the lower arch, and then we keep it in a functional class 2, then those are the cases where a relapse of deep bite takes place. And more significant in dental deep bite treated cases with a posterior extrusion rather than skeletal. So to conclude, vertical discrepancies consist of various components of the craniofacial complex. The clinician must establish differential diagnosis of vertical problem, as it forms an integral part of the designing a successful treatment strategy. It is imperative to understand that all cases cannot be treated in a similar manner owing to variations in facial growth and morphologic characteristics. Hence, individualized treatment plan should be formulated. Thank you. Wishing you all healthy and a safe 2021.